All right, welcome back, friends. Today we're going to talk about one of my favorite regions of the body, which is your temporal and infratemporal. And you're probably wondering why I'm such a big foodie. And you know what? This area has a lot of things related to taste, eating, um, just your general day-to-day things that we cherish. And so, what are the topics for temporal? We'll start with the main topic is infratemporal region or infratemporal fossa. But first, we have to understand what is a temporal to understand what is infratemporal, meaning what is underneath the temporal. And then particular interest is that there's a lot of things that go through this infratemporal fossa. So things such as muscles, and I'll write mom for now. There's nerves here. There's also some arteries and veins here. So arteries is especially your maxillary artery, and then your pterygoid plexus nerve system. So that's why it's important. First, I have my muscles and mastication, which I call mom and her friends. So muscle and mastication and some accessory muscles. Then we will talk about the nerves, especially V3, the chorda tympani. That will give us. So V3 gives us sensory to the tongue, whereas chorda tympani will give us some taste and some gland parasympathetics. Chorda tympani, and we can also talk about CN9. Okay, CN9, which is otic ganglion. Next will be the maxillary artery and then the pterygoid plexus. Interesting thing for a dentist is that inside the space we can also have our second topic, which will be TMJ. I'll just write that in part 2. Will be TMJ, and then TMJ is in the space, basically sitting in the condyle in the mandibular fossa. So in the TMJ side, all we have to talk about is the TMJ, the ligaments, and the mastication space, and all of the structures. And masticator space. Okay, let's jump right into it. So first, like I said, to know what is temporal, infratemporal, which is our interest, we have to understand what is temporal. So just a real quick overview I will do. So this is our temporal region. Everything underneath that is your infratemporal region. But you have to remember that there is the mandible is lateral to all of this. So mandible is overlying all of that. So we have, as you can see in the picture, we have a lot of structures, arteries, veins, muscles that are basically either inserting or coming out. Something's happening here. And here you can see a better picture. So we're looking at the maxillary teeth, the maxillary molars here, and then our infratemporal region is everything basically under the zygomatic arch, or medial to the zygomatic arch, under the maxilla itself and the zygomatic bone. And it comprises a lot of, so here's my ovale, here's my spinosum, here's my styloid process that will have a ligament attached to it. There's a petrotympanic fissure. So I'm just doing a quick overview. Now let's talk about the boundaries. So like I said, to note infratemporal, we have to talk about the temporal region. So at first we will do the temporal lines. So that is a superior boundary. Anteriorly, we have the zygomatic and some maxilla involved. Inferiorly, we have this plane that runs from the zygomatic arch to the infratemporal crest. So that's your inferior boundary. Interesting thing here is that inferior boundary becomes your superior boundary for your infratemporal region. So that's the interest to us. So in infratemporal, our superior is that zygomatic arch, that plane. And if you can look on the picture on the left, that is the plane that we're talking about. So that plane that separates is your superior boundary. Then you have the infratemporal, the maxilla. So the maxilla is anteriorly, and on the bottom you will find the mandible, and then medial you will find the pterygoid plates. So those are the pterygoid plates right there. Talking about the contents that are important or important to us to learn about, in the superior boundary we have something called the infratemporal crest of the sphenoid bone. Like I showed you, we have foramen ovale that carries V3, mandibular branch of trigeminal. We have spinosum that has middle meningeal artery. Then we also have the chorda tympani that will provide us taste to the tongue. And then from temporal, we have some contribution such as the mandibular fossa, eminence, and tubercle. So looking at that here, where my condyle will sit here in purple or now in red, that is my mandibular fossa on the temporal side. The anterior of my mandibular fossa will be, so right here, the anterior portion that will limit its movement to the front. So basically, limits our opening jaw maximum. So your maximum opening is limited by that articular eminence. And then basically the pointy thing on the zygomatic arch is articular tubercle. So if I just draw like a basic representation, there's my mandibular fossa, one I have, and then here's my zygomatic arch, for example. And then I have this pointy articular tubercle, and then in the front here, what's limited is my articular eminence. So now let's jump right into mom and her friends. So muscles of mastication are innervated by the mandibular branch of trigeminal V3, and here we will start first with the temporalis muscle. So temporalis starts on basically in the temporal region. We have the temporal fossa, that's the origin, and it will insert into the mandible, the coronoid itself. So here, I don't know if you can see it here. Here it is attaching to the coronoid process of the mandible, so that's a process in the front, and then also to the anterior of the ramus. And this is kind of important because you will see another muscle, which is our masseter, that will also insert into the coronoid, and also, but now it's different, is that it will insert into the lateral ramus. And let's look at that one. So here you can see the masseter going, but it's now inserting into the lateral ramus. That is the only depiction. So here we have another picture. We have temporalis comes and attaches to the anterior surface, whereas we had the masseter that came from the zygomatic arch but attached to the lateral ramus, and especially to the coronoid and the angle. So masseter is more outside, is more lateral. Temporalis is more medial, inside of the mandible. So those are two of our muscles. Then we talk about the medial pterygoid. Medial pterygoid, we have two heads, the superficial head and the deep head. They both insert into the mandibular ramus, but important is that, let's talk about the origin. It starts from the pyramidal process of maxillary tuberosity, and the deep head is from the medial of the lateral pterygoid. So that's how it's named, medial pterygoid. Here we can see the medial pterygoid coming in, and both are inserting into the mandibular medial of the ramus. Mandibular ramus, and then here we also see our lateral pterygoids. What's important here is, if you can see the picture, we have the sphenomandibular ligament that will always course between the two pterygoids, between the lateral pterygoid up top and the medial pterygoid at the bottom, and that will always carry the IA, the lingual nerves. Next, we talk about the lateral pterygoid, and lateral pterygoid is particularly important because this is where you might find the long buccal nerve that runs in between the two heads of the lateral pterygoid. So talking about the origin of the lateral pterygoid, superior head is in the greater wing of the sphenoid bone. Inferior head is on the lateral side of the lateral pterygoid, therefore it's called lateral pterygoid, and now they will insert into the condyle. So this is the only muscle so far we have seen inserting into the condyle side and the TMJ capsule. So here you can see this is where the condyle will sit, and this muscle is attaching into that condylar area, or the TMJ capsule. Now if we talk and just do a quick review, here we can see temporalis inserting into our anterior portion of the ramus underneath the zygomatic arch. It's not really, here you can see after it's broken, after the zygomatic arch is broken. So that is your temporalis. Masseter is more on the lateral portion and anterior of the coronoid process. There's masseter, and we have medial pterygoid that attaches on that from the medial side of the mandible ramus and attaches to the you can see to the medial side here of the pterygoid plate, whereas on the lateral side we should have the lateral pterygoids. So there's medial pterygoid and there's lateral pterygoid. And then we have some other friends, such as posterior belly, digastric, stylohyoid, mylohyoid, anterior belly, geniohyoid, all of these accessory muscles that want to help. Here, I think it's just trying to show you that how you have the buccal nerve, which is traveling in between the two pterygoids. And then we have a sphenomandibular ligament that carries both of the lingual and IA nerve, and it travels in between your lateral pterygoid on the top and medial pterygoid on the bottom. Next, let's just talk about real quick those accessory muscles. So here's just a little exception to these rules, is that anterior belly is V3, whereas posterior belly comes from 7. Then we have mylohyoid, geniohyoid, buccinator. They have their respective origins and insertion. Anterior belly origin from the digastric fossa, inserts into the intermediate tendon of the hyoid bone, whereas posterior belly also inserts into it, but it origins from the mastoid, from the back of the temporal bone. The mylohyoid muscle starts in the mylohyoid line on the mandible and will come into the hyoid bone. Geniohyoid, a little bit above that, will start from the mental spine and insert into the hyoid bone. And then buccinator is basically behind mylohyoid, starts in the mylohyoid line and inserts into that pterygomandibular raphe and into the outer lips, orbicularis oris. What's important is that you have a pterygomandibular raphe, this ligament, and from anterior, from one side, you have the buccinator that's attached, and from posterior, you should have the superior constrictors that's attached. Now let's talk about all the nerves that are inside of that infratemporal region that we've been talking about so far. Here we will talk about mandibular branch of trigeminal, and it gives afferent and efferent. Afferent gives us just general sensation to the tongue and cheek area. I like lila better, so long buccal, IA, lingual, and auriculotemporal. Here we can see long buccal that's going to our cheek area. Then we have lingual that branches, provides some type of sensory innervation, also gives some branches to some mandibular gland. And then we have IA. IA will split into nervomylohyoid. IA will enter the mandibular canal, mandibular foramen. Once it comes out here, mental foramen, it gives out incisive nerves. And then we have auriculotemporal. Auriculotemporal is important because in this region, basically right here, try to erase it for you. Here you can see auriculotemporal. Here you can see auriculotemporal wrapping the middle meningeal artery as it's entering our spinosum. So once again, here it's a better representation. We have V3. We have the IA that's entering. Here's we have long buccal going to the cheek area. Once IA comes out of the mental frame, we call that mental nerve. As it keeps going, we call that incisive nerve. That's about it. And here's lingual nerve on the underside. And then another thing that's significant is that you should have a parotid duct that will kind of wrap underneath of the lingual nerve here. That's later. You can see it right there. So here you have the parotid duct. Sorry, not the parotid duct. It's a mandibular duct that's wrapping underneath our lingual nerve. Sorry, my brain is thinking one thing and I'm saying something completely different. Next, we have the chorda tympani. Chorda tympani is what gives us taste to the anterior 2/3 of the tongue. Here we just have 2 pictures. We'll come back to these. The cell body is in geniculate ganglion. It's a branch of 7 facial, and it will join lingual branch of trigeminal V3. So what is my chorda tympani? So chorda tympani is right here. It's coming from facial through the petrotympanic fissure. Right there, we can make that, joins lingual, and then it will give some branches to provide some parasympathetics to the gland, and also wrap underneath the artery, and then go to the, basically provide us taste to the anterior 2/3. Next, we can show here, I think here it's trying to show you how the facial nerve gave you chorda tympani. And chorda tympani, after it goes through petrotympanic fissure, joins lingual. After joining lingual, gives some branches right here to submandibular ganglion, and then it will give you taste to the tongue. Once again, here is chorda tympani, petrotympanic, submandibular ganglion, and then sublingual gland, and then to the taste underneath the tongue. So the maxillary artery is the terminal end of this external carotid right here. So external carotid gives you maxillary coming in and superficial temporal going up. Then we have 3 parts, and they are related to the lateral pterygoid. So the first part is right here. We should have the inferior alveolar that we see going down into the mandibular canal, and then we see the nerve to the mylohyoid going back there. We should have, so that's IA, and then we should have a middle meningeal that goes up, basically. Don't see it here, but we saw it earlier where that auriculotemporal goes up, and then it's wrapped. Middle meningeal goes up, and it's wrapped by the auriculotemporal nerve running. So the second part is on top or underneath the lateral pterygoid, and this is your muscular branches. So you can have some branches going to the temporal region, some branches that go to your masseters and the pterygoids. And then third part is important here. The third part, we see the branches that go once maxillary enters the inferior orbital fissure, then it will be called infraorbital artery, just like the nerve sequence. And then the second artery here is posterior superior alveolar that supplies to the maxillary teeth. And then we have third one that enters palatine artery that enters through the pterygopalatine fossa into the nose, and then fourth one is just descending, goes to the front or hard palate or soft palate. So that's your descending palatine artery. Here we can see we were talking about the pterygopalatine fossa. So sphenopalatine will enter the pterygopalatine fossa, and that's basically like this way. It will go to the nasal cavity. Whereas inferior to the pterygopalatine fossa, going down from that ganglion is going to be maxillary. It's like maxillary going to the hard and soft. Or basically here goes in, and then you have something that goes hard and soft. Now, just a small depiction. Pterygoid plexus, the venous system, wraps around the lateral pterygoid, just like how the maxillary artery is in relationship to the lateral pterygoid. Pterygoid plexus is around the lateral pterygoid. It will drain right here into the maxillary vein. That's all I have written on the side. Pterygoid plexus will drain into the maxillary vein. With the superficial temporal, will form the retromandibular vein, and then will become either external or internal jugulars. And if we talk about the cavernous sinus can communicate. Cavernous sinus can communicate with our pterygoid plexus via emissary veins, and they also exit through foramina valley. So something that's very important to the dentist is the TMJ movement, and even to any kind of person, because this is what I'm doing right now to speak and chew and eat. So TMJ movement is 3 types of movement. You have the hinge, glide, and lateral movement. So let's do the first one. The gliding movement is translation. The second one, hinge, is rotation. Third one, lateral, is side to side. So gliding is Gliding is front to back. Hinge is the hinge of the door, opens and closes, but just imagine the door being like on the ceiling, so opening and closing the door, elevation and depression. And then finally lateral side to side, which is done by all the muscles of mastication, all the moms. Uh, and then if we talk about the gliding movement, like we said, is translation, protrusion, retrusion. It happens in the upper joint cavity. So if we go into the picture right here, here we have the articular disc in the middle. We have two purple lines, one above, one below. The upper one is upper joint cavity, and the lower one is lower joint cavity. So let's see what happens. So the gliding happens in the upper joint cavity. So this is for gliding, and then this is for hinge movement of the lower joint cavity. So rotation happens in the lower joint cavity. Where's some of this? So once again, gliding, protrusion, retrusion from back when the disc glides on the upper joint cavity inside the eminence, right? We know the articular tubercle, like we talked about earlier, mandibular fossa, where the condyle is sitting. All of that is helping a movement. Then we have rotation, which is up and down. Elevation, depression is when the head rotates in the lower joint cavity. So now we're just talking about the condylar head in the lower joint cavity. Next, we can talk about synovial joint. Synovial joint is made up of a capsule, hyaline cartilage, and the fluid. It's located between the head and the mandibular fossa, so it's just sitting there basically in space, and that's what we call upper and lower joint cavity. We have the mandibular condyle, the convex surface, and its extension. If we draw a line straight from there, the mandibular fossa, we should intersect them in foramen magnum. That's in low yield. A few things in relation to temporal bone we've talked about earlier is mandibular fossa, where that condyle head sits. The tubercle, it's that pointy thing between the fossa and the zygomatic arch, and then the eminence, which prevents the gliding, basically too much of the opening of the jaw or our maximum opening. The articular surface is hyaline cartilage, and then we talk about the capsule here. You can see here we have a capsule. In front of that, we have this ligament that is preventing it from popping out, lateral displacement. We also have two ligaments on the inside. We have this phenomandibular that will give me the IA and nerve to lingual nerve also, and then we have the stylomandibular on the backside here. And this is actually important, is that the stylomandibular is, if you can imagine, is the inferior border of that infratemporal region. If we just imagine it's from the medial side of the mandible all the way to that the plane we were talking about from zygomatic arch to the infratemporal crest. So this is what the infratemporal region would be. Okay, going back. The articular capsule externally on the outside where we're seeing it's fibrous, and on the other side it's synovial fluid. Superiorly, it's sitting loosely in the mandibular fossa, like we said. Anteriorly, it's tightly joined to the lateral pterygoid as well as the lateral ligament. So here we should have the lateral pterygoids that will attach here. We already have our lateral ligament in the front, and then medially on the other side, it's attached to the condylar neck, and it's tightly attached. Lastly, let's talk about the articular disc. We know it's a biconcave fibrous disc. Above, below, we have the joint cavities. What else? We have a thicker part at the posterior end. It's more bilaminar, highly vascularized, more cells, and it's also innervated by the V3. Then we have field ligaments that in the space. So we have the lateral ligament that prevents the lateral movement that we can call the temporal mandibular ligament. Medial side, we have the phenomandibular ligament where we find the lingula, the IA, and all of those structures. And inferiorly, we have the stylomandibular ligament. So here we can see we have the lateral ligament right here. In front of the capsule, we have the stylomandibular ligament. I believe is not here. We have stylohyoid ligament, and then yeah, that's about it. Here's another picture. So here we have sphenomandibular ligament, providing that hammock for those nerves, the stylomandibular ligament, and then we should have the lateral ligament on the mandible. And now if we just talk about some spaces, we have the masticator space. Masticator space encompasses all of the muscles of mastication. If we look at most lateral muscle, is going to be our masseter, and we can have our temporalis, and then we can have, if we go more inside, let's say this is our tongue, just kind of a random drawing, masseter, temporalis, and then we can have our pterygoids. Let's see, lateral pterygoid, medial pterygoid. It's probably not a good way to do this, but oh well. And this space will go from the lateral side of the medial pterygoid to the medial side of the medial pterygoid. Sorry, lateral side of the masseter and temporalis, and to the medial side of the medial pterygoid, and everything in between will be masticator space. And it's made up of the investing cervical fascia. Like I said, it can have the maxillary artery, the V3 mandibular branch of trigeminal, the pterygomandibular ligaments, and we also have two spaces. We have lateral pharyngeal space and pterygomandibular space. But we can see that here they are not touching each other; that they're separate. They do not communicate with each other. Once again, the contents of the masticator space, you have the temporal and infratemporal, you have the sphenomandibular ligament, the nerves that are inside of there, buccal fat pad, and so on and so forth.
Yeah.